When I started work, there was no such thing as multi-drug resistant TB. In fact, it was an interesting time because it was just very close to the time when rifampicin was first discovered. Now, you could try to work backwards, you could perhaps work that out, but I'll leave that to another time. The phrase multi-drug resistance is actually an unfortunate one, because if you think about it, if you said to somebody working in multi-drug resistant TB, you think, well, that means in TB where there is resistance to more than one drug. Unfortunately, it's not quite as simple as that. I don't know who coined the phrase, but I think it was not the best phrase. Having said that, I don't think I could come up with a better one. Because, of course, you can be resistant to a number of drugs, which is not necessarily more than one drug, but not have MDR TB. These days, patients who, in fact, who have resistance to rifampicin, whether or not they have resistance to any other drug or not at all, could be with isoniazid, which is what the classic definition of MDR is, are usually treated in much the same way as to whether they have MDR plus with other drugs or just have mono rifampicin resistance. Now, so it's very interesting that TB was considered by Archie Cochrane, and all of you will be familiar with the Cochrane collaboration idea, and it's named after Archie Cochrane, who was an MRC epidemiologist working back in the 1940s and 50s. Archie Cochrane used to say that TB had the best evidence base of any disease, for treating any disease. Whether that's still true today is a good point. And it's not particularly true, certainly for multi-drug resistant TB, because it is true that, in fact, it has been until relatively recently. We talk about in relative terms, I'm talking about within the last 5 to 10 years. In fact, it's been very much a neglected area. It's been the Cinderella of TB work, really. But it became evident as rifampicin began to be introduced and more people began to develop resistance to TB. And so you could acquire a rifampicin resistance, or you could be infected by somebody with rifampicin resistance. And indeed, there was a major effort, incidentally, by the Union, International Union Against TB and Lung Disease, to say that rifampicin should not be given for more than the initial intensive phase, because if it was, there would be real problems of having it out there when the drug wasn't being supervised properly, and MDR TB would develop. Just in terms of numbers, we are today in a situation we have about 10 million new cases of TB every year, and about 500,000 of those are rifampicin resistant. But nobody was terribly bothered to do much about it until in the late 1990s, a series of cohort studies were conducted by one Armand van Dern, working with the Damien Foundation in Bangladesh, to try to develop something which was better than what WHO were recommending, which at that time was really based on nothing more than expert opinion and a few cohort studies. Armand himself did a cohort study. In fact, he did 6 cohort studies. The last of these reported that a regimen given to 206 patients for just 9 months, which was considerably shorter than what WHO was recommending at the time, which was the order of 2 years, had a relapse-free cure rate of just under 90%. And a lot of people were very excited about that. Some people said, well, that's what we should all be treating everybody with. Other people were much more hesitant and said, well, that's what's going on in one particular setting, a setting where there's no HIV, for example. And in fact, it's a cohort study, it's not controlled. We don't quite know what it would be like if we compared it with other treatments. And so we were asked at the MRC to design a study in patients with organisms resistant to rifampicin, but susceptible to fluoroquinolones and aminoglycosides, to see whether those Bangladesh results could actually be replicated in another setting. And this was the stream stage 1. Now, I'm here to talk about stream stage 2. We'll get to that in just a moment. And stage 1 was a non-inferiority trial conducted in Ethiopia, Mongolia, South Africa, and Vietnam. And the results were based on long-term outcomes at about the 2.5-year point, because we were comparing the WHO long regimen of 20 to 24 months with a 9 months shorter regimen. And the results were very interesting. In fact, very, very close, just 1% difference between the two of them, which fortunately for us achieved non-inferiority because the upper limit for non-inferiority was a difference of 10%, and we actually got a confidence limit where the upper limit was 9.5. And the proportion of patients who experienced a grade 3 or greater adverse event at any times was similar on the two regimens, which was disappointing. We hoped the shorter regimen would actually have fewer side effects. But we did actually look incidentally, not just at when people were on treatment, but the whole treatment follow-up period. And quite a lot of people had what we'd call a severe adverse event, said 48% compared to 45% on the two regimens. Now, before we completed stage 1, and we hadn't looked at any data, we didn't know what was going on. And on this particular occasion, I wasn't the statistician because I was the chief investigator or the co-chief investigator alongside a clinician, Professor Sarah Meredith. We were invited to actually expand the study and assess some additional regimens or additional regimen or two with the new drug bedaquiline, which in fact had only just received provisional licensing. The question that we were addressing was, could bedaquiline substitute for the injectable kanamycin, which had its problems, not least with problems of deafness? Could it also be used to further shorten the regimen? Now, stage 2 was predicated on the assumption, and as I said, we didn't know the result of stage 1 at that stage, that the 9-month regimen studied in stage 1 was non-inferior to the long WHO regimen. Now, if we declared this 9-month regimen as the new standard of care, that could result in biocreep. In other words, what we could be accepting an inferior standard, something which wasn't really quite as good. And as time went on, you might be slipping and having a reduced efficacious standard of care from one study to another. And with that in mind, we decided to retain the long regimen in our design of stage 2. So we could compare not only with the 9-month regimen, our new regimens, but also with the WHO long regimen. And these are the regimens. The long regimen is the locally used WHO 2011 recommended regimen. The control regimen was basically the regimen used in Bangladesh. There was only one difference between what was seen in Bangladesh was that moxifloxacin was here included rather than gatifloxacin, because gatifloxacin is no longer being produced, or in fact it is produced, but not to good manufacturing standard. And so it was actually based on 7 drugs. Now, some of you may have questions about why we needed 7 drugs. I think we'll leave that to question time rather than I explain it right now. It was based on 4 drugs given throughout the 9 months, plus kanamycin, isoniazid, and prothionamide given in the initial intensive phase. The oral regimen saw kanamycin dropped. This is why it's in red here. We got it here, but not in this regimen, and bedaquiline introduced. And that's the only difference, apart from having levofloxacin as in place of moxifloxacin, because there was a contraindication to using moxifloxacin with bedaquiline. And then we had a 6-month regimen. This was very much a sort of shot in the dark as to what would happen. It's very similar to the oral regimen, but we brought back kanamycin, but dropped 2 other drugs. We dropped the ethambutol and we dropped prothionamide. Didn't think ethambutol was probably doing very much. And we thought prothionamide might be doing more harm than good. More of that a little bit later. The intensive phase in this stage was in fact 16 weeks compared to 8 weeks. Sorry, 8 weeks compared to 16 weeks in the other 2 regimens. The study timeline, the study began, and there was quite a bit of delay. The reason there was a delay was that, in fact, we were able to do this study, not just because USAID were funding it, but because Janssen were very keen to do a definitive study to get the full licensing of bedaquiline. And it took a long time negotiating with Janssen in terms of actually what was going to be included in the study, and particularly all the safety data that would be actually required. Patients were enrolled in Ethiopia, Georgia, India, Moldova, Mongolia, South Africa, and Uganda. The enrollment to the WHO regimen, however, was stopped very early because countries began to adopt a standardized 9 to 12 month regimen following the WHO 2016 guidelines. Unfortunately for us, but not necessarily for South Africa, in August 2016, the South Africans adopted a shortened bedaquiline-containing regimen across the country. So we were not able to enroll any more patients from South Africa. And because we were therefore struggling a little bit with enrollment, in order to ensure sufficient participants were enrolled to the oral versus control comparison, enrollment to the 6-month regimen was stopped later in 2018. But it wasn't stopped in India. The Indians refused to stop. They said, we want to follow this, we want to include this regimen, please include it, continue to include it in our sites. And so we had to include that regimen in the Indian sites. We revised our sample size calculations. Now, non-inferiority studies usually work on the basis that you assume that your two treatments are of equal efficacy. And that's the assumption that I made when we did the power calculation for the study. That makes quite a lot of difference in terms of how many patients you require, because thinking about it as the study went on, we thought, and we were not aware of any results at this stage, our assumption had been that both study arms would have both the control arm and the oral arm would have an 80% efficacy. Thinking about it as the study was going on, I thought, well, surely we could expect to do a bit better with bedaquiline instead of kanamycin. Bedaquiline surely is a better drug. So we took this step in the dark because we didn't know what the results were, assuming it would be 82% versus 80%, which really made a lot of difference to the power calculations and brought our numbers down quite a lot. Our margin of non-inferiority was 10% with a one-sided significance level of 2.5 and 80% power. And that required 200 patients to be enrolled in the control and oral regimen, assuming that 14% would be excluded from the per protocol analysis population. In other words, patients, in fact, who for a variety of reasons, not because they were doing badly from their TB point of view, but for other reasons had actually might drop out of the study. Enrollment was completed in January 2019, was very fortuitous, really, because it was just before the COVID pandemic really took hold. And here are the baseline characteristics, looking at those two regimens, the control and oral population in the MITT population patients. You'll see that almost 2/3 of them were male. The majority of them were in the age group 25 to 44. We had HIV positive patients, about 13 or 14%. A fairly substantial proportion of them had advanced disease on chest radiograph, and certainly cavitation. There was plenty of cavitation. About 50% of them had multiple cavities, and the smear status was 2+ or 3+ in about 70% of patients. The primary question that we were addressing was, is the proportion of participants with a favorable efficacy outcome at week 76, that's about 18 months after randomization, on the oral regimen non-inferior to that on the control regimen? In other words, was it as good? Our favorable status was considered to be having a negative, the last two negative cultures being negative, and the latest one of those had to be in the window of the 76-week assessment. Unfavorable was a composite endpoint. It wasn't a straightforward one saying, are they doing badly bacteriologically? Was their TB doing badly? But it also included people who died for any reason whatsoever, treatment change for any reason, including toxicity, drug adverse events, and indeed loss to follow-up. So it was a complex endpoint, composite endpoint. And this is the primary result. In fact, we were very pleasantly surprised to see the oral regimen had a success rate of nearly 83% compared to 71% in the control regimen. What's very interesting is to look at the breakdown as to why people had an unfavorable outcome. You'll see in the control regimen, almost 11% had an unfavorable outcome for bacteriological reasons compared to just 4% in the oral regimen. And in both regimens, non-bacteriological reasons predominated. The difference in response was 11%. It was a big difference, and it didn't just achieve non-inferiority, it also showed that the results were actually highly statistically significant. The oral regimen was doing much better than the control regimen. So we could have assumed bigger than a 2% difference. We got an 11% difference. What were the bacteriological reasons for an unfavorable outcome? Well, on the control regimen, they were mainly either bacteriological reversion during treatment. This means patients who became culture negative, but while still on treatment, actually reverted and became culture positive again, or they were treatment changed to persistent culture positivity, patients who never actually converted to culture negative. The smaller number of patients who had bacteriological reasons on the unfavorable regimen, the majority, they were just scattered really, about 3 of them had reversion during treatment. What about the non-bacteriological reasons? Well, you can see that predominantly these were treatment changes after an adverse event. There were 20 on the control regimen and 6 on the oral regimen. We actually had a definition, which is a slightly complicated one. If you changed 2 or more drugs, that was considered to be unfavorable, unless you started bedaquiline, the injectable, or linezolid. And in fact, interestingly, a lot of patients did start linezolid on the control regimen when they failed. So on the oral regimen, or the only 6 cases that did start, they started linezolid. Here, 6 of them started the injectable on the oral regimen. So very briefly touching on safety, because we don't have time to really go into that in much detail. I just want to pick up 1 or 2 highlights. The safety population was everybody who was randomized to these 2 regimens. The proportion with an SAE, a serious adverse event, was very similar, as was the participants with any grade 3 or 4 adverse events. And indeed, it was about 50%. Half the patients had a grade 3 or 4 adverse event. But changes due to an adverse event were 30% on the control, but only 18% on the oral regimen. There were really few deaths, which was encouraging, and they were for a variety of reasons. And as I said, death for any reason was considered to be unfavorable. In terms of grade 3 or more adverse events by the most common MEDRA system classifications, you will see that, in fact, the commonest of these was actually QT prolongation, occurring in about 1/4 of patients on both regimens. That having been said, most of them only had an increase of 60 milliseconds or more, but they didn't cross the threshold of 500 milliseconds. So you look at the bottom of the slide, there was only 6% of patients on the control regimen compared to 3% on the oral regimen who actually had QT prolongation, which took them over the 500 milliseconds mark. You can see the hepatic disorders were similar in the 2 groups, and nutrition disorders as well. And there were quite a lot of laboratory investigation which were considered to be abnormal at grade 3 result. But what's particularly important here is, of course, the reduction in the hearing and vestibular disorders, which dropped from 10% just to 3%. And of course, some of those patients may not have been anything to do with their drug. Some of them might be elderly patients who were just developing, their hearing was disappearing as they got older. So in summary of the main findings, the oral versus the control finding was the efficacy was superior, clearly superior, the oral regimen. Bacteriological failure or recurrence was less likely to occur in the oral regimen. Safety profiles of the regimens were generally very similar. Small number of deaths, no clear pattern. Grade 3 or 4 adverse events were common on both regimens. Severe hearing loss was substantially reduced in the oral regimen. That was an important finding. And QTCF prolongation was common, but increase of greater up to 500 milliseconds or more was observed in only a small proportion of patients. I want to finish just briefly with just a quick word about what I think is probably the most interesting finding, the one in which we, in a sense, we curtailed our power to be able to do this when we wanted to make sure we could do the primary comparison. That is looking at the 6-month regimen compared to the oral regimen. In other words, the best of the two 9-month regimens, which is the oral regimen, which we showed was definitely superior to the control. And we were very pleasantly surprised that 91% on the 6-month regimen had a favorable outcome, compared to just under 80%, not 79%, who received the oral regimen. And again, bacteriological reasons were very small, only 2.2% on the 6-month regimen, 4.6% on the oral regimen. And my final slide, although I've got one or two hidden behind, which I might refer to when questions come, is if we look at any grade 3 adverse event, 6-month regimen was slightly higher, it's true, than the oral regimen. QT prolongation, again, occurred on the 6-month regimen a little bit more frequently. Hepatic disorders were slightly less frequent. Hearing and vestibular disorders, this is really important because the injectable was still being given in the 6-month regimen, but for a shorter period of time, were just 4% compared to 2% on the oral regimen. And two patients died on each regimen. Now, in my mind, I want to stop there because I'd be very interested to know what your questions are, but I'd also be interested to know, because I'm going to ask you a question if you don't ask me one, as to why you think the 6-month regimen did actually do better than the 9-month regimen, bearing in mind it had fewer drugs, and bearing in mind everything about it, and it was given for a shorter period of time as well. It raises interesting questions.
Thank you. Right, who wants to respond to Andrew's question? Who wants to fudge it by asking you questions?
Well, I'm going to fudge it by asking you another question, but we'll try and have a think about the question you posed to us. I just wonder, just if I got it correctly,
Sorry, keep my slide.
the bacteriological failures in the injectable regimen, you said were because of reversion, so people that converted and then reverted while on treatment.
Sure.
I just wanted to know if you knew when that occurred during the treatment. So was this people that converted while they were on the intensive phase, and then when you went to the continuation phase?
Yes, they did. Yeah, they did. In fact, the culture conversion occurred in almost everybody by about 8 weeks. And the intensive phase was 16 weeks, actually, on the 9-month regimen. It was 8 weeks on the shorter regimen. So it did actually occur early on. And then there'd be a month or two, or yes, while they remained culture negative, and then it reappeared. Now this is unusual. I mean, I've been involved in a lot of studies in drug-sensitive TB, and actually reversion on treatment is very unusual in my experience. Actually, it doesn't happen very often. You have people culture convert and then revert. If you have really culture converted, then on treatment, it usually remain culture negative. Certainly in many of the trials that I've been involved in the past. So this was slightly unusual. In other words, it was more common than relapse. We didn't have many relapses at all. Very few relapses.
But then we see something to find out if it was actual reversion. Sorry.
Oh, we did incidentally include reinfections in the unfavorable. There were some patients who were reinfections, but none. But these were not reinfections. No. These were actually, they were infected with the original strain. Yes.
What's that telling you about the efficacy of drugs?
Well, one of my take-home messages is, you can look at it on this slide if you like. Well, I mean, do you mean the reversion issue, or do you mean the reversion? I mean, it's not an issue on the 6-month regimen, really, because in fact I haven't got the breakdown of those threes, what they were. I can't remember offhand exactly what they were, but it does seem to say something about the 9 months regimen in terms of the fact that it wasn't able to sustain that culture negativity. I mean, one of the things in terms of talking about the efficacy of the drugs in general, just isn't quite answered your question, but in terms, these results to me suggest that we've got drugs which are very effective from a TB point of view. I mean, this 6-month regimen has a unfavorable bacteriological rate of about 2%. But the unfavorable rate is really the composite endpoint of people, in fact, who are having to change their drugs because they can't tolerate the drugs because of side effects. That is also, you're seeing that in other studies as well. Practical study, interestingly, they didn't have any in the initial findings that when they were first shown. And I don't think they had many when in the final results, which are shown at the Union Conference. In fact, they had practically no failures or relapses, but they did have their unfavorables were deaths and failure to tolerate the regimen. That's how the unfavorables are measured, actually. So we've got good regimens from the point of view of the TB, but not good regimens from the point of view of tolerance by the patients, really. And it does actually raise this my questions I was going to ask is, what's the explanation for the good performance of the 6-month regimen compared to the control and all regimens? Is it because it's the bedaquiline and kanamycin combination, the presence of the kanamycin there as well as the bedaquiline? In other words, the kanamycin is really doing something which, in fact, without it, you don't get such a good result. Is it the absence of prothionamide? That might seem a funny thing to say until you realize that if you've ever had prothionamide or you actually know anything about it, it's a very unpleasant drug to take. And the prothionamide may well have led, or did lead, into quite a number of cases to people having to change their treatment because they couldn't tolerate it. So they became unfavorable under that composite endpoint. So you were better off without it than actually having it in there in the first place. I have other questions here, but we haven't got time to talk about this. So I think the clock has moved on, so I've probably talked for longer than I should have done already. And
so I was going to say, you talk about reversion. I'm not sure what you mean by
reversion is that you clearly, I mean, we have a definition for culture conversion is you have to have negative cultures on at least on 2 consecutive occasions separated by length of time varies from people's different definitions, but they do definitely 2 separate occasions. So it's not just a single negative culture, but in other words, you've got confirmed negative culture conversion. And reversion is that when having done that, your positives start to come back, you come back again. And in other words, it's not an isolated positive either. If it's a single isolated positive, we wouldn't be worried about it. But in fact, in other words, the patient then, I mean, it's a pity I could have shown you an individual case, but you've got somebody who's become clearly culture negative, confirmed over 2 or more months, and then in fact then they have a whole string of positives thereafter, cultures. So that's what's happening bacteriologically. So
it's a treatment failure. So
it becomes their treatment failures. Yes, they're failures in the sense that they're still on treatment and treatment has failed. They're not quiescent at the end of treatment. No, they're failed.
So because it's not two. It's not two. So then the point becomes important, doesn't it? Work out whether it is a relapse or a reinfection.
Well, if you call it a relapse, it's relapse on treatment. That's why it's called reversion rather than relapse. But yes, you're right. These were not reinfections. This is my
So how do you know that?
because we compared the strain with the baseline strain.
Sequencing.
Yes. Yes. No, that's was the case. Yeah.
So then building on that, well, you've got a 2 complicated experiments, haven't you? Because you've got 2 variables to work out. So your question about the absence of polymer, that can like this sort of thing, but it's the experiment.
I mean, this absence of prothionamide is purely me. I have nobody else has suggested that. I mean, I'm aware that in fact that we got less adverse. In fact, the rate of culture conversion, incidentally, we obviously hadn't got time to show you that. Culture conversion rates between the 2 regimens were almost identical. They were pretty overlapping. There was no suggestion that those who were getting kanamycin were culture converting more rapidly. But everybody, having said that, we didn't have weekly samples. We were only looking at 4 weeks and 8 weeks, and by 8 weeks, everybody was culture negative pretty well. Very few were not. Very few, just 2 or 3. Very small number of patients. So it's possible that between week 0 and week 4, in the first 4 weeks, there might have been evidence some faster culture conversion, but obviously we don't know that.
And the study design was maybe.
No, but I mean, it's a bit like a factorial design with or without kanamycin. And as I said, if you sort of assume, I mean, taking the prothionamide out, I mean, it's not going to do taking it out unless it was antagonistic at all to other drugs, which I suppose is possible. I don't know if we know any evidence for prothionamide being antagonistic. I mean, that's a thought. So just come to me whether that was a possibility too. But in simple terms, it looks as though it's the kanamycin. Having the kanamycin has actually made a difference because that's the ethambutol. I think you can disregard the ethambutol. I don't think that. I mean, taking the ethambutol out, there's no reason to think that sort of made it more. Well, it might have made it a little bit more tolerable, but by and large, ethambutol is a reasonably tolerable drug. It's not so bad as prothionamide. I mean, there are other questions here. I mean, incidentally, I mean, the activists at the union conference were sort of saying, well, why you shouldn't even be studying a 6-month regimen. Of course, that study began some time ago because, of course, they believe that it's almost unethical to give somebody an injectable. Not everybody has quite such strong views as that. I don't know if anybody's got views on that here. I'd be interested to know.